Morning. So today I'm going to talk about negative pressure wound therapy. The idea started kind of, it seems like we use it a lot more in joints. And then I was interested, obviously, kind of its application in spine, for which here we don't really use much of it. So I just kind of ended up looking into the history of it and then trying to see what the recent literature shows. So we'll kind of talk about the history of negative pressure wound therapy, where some of the research started in other subspecialties, and then we'll kind of end discussing its relationship in spine surgery. So I have no disclosures. So we'll start off by talking about some of the proposed mechanisms, as well as even at a cell biology level, how negative pressure wound therapy works. And then we'll talk about some of the different options that exist out there currently today on the market. We'll discuss briefly the epidemiology and risk factors for surgical site infections, some of the indications, contraindications at the end, and then we'll look at kind of the development of literature over time and where we're at today as far as spine surgery goes. So 1 second here. So surgical site infections are, obviously a pretty big issue in regards to patient outcomes as well as healthcare associated costs. So some of the recent published literature shows that over 700,000 healthcare associated infections occur yearly, and greater than 20% of those are associated with surgical site infections. Overall, this leads to increased hospital length of stays greater than 9 days. And on average, this increases healthcare associated costs greater than $38,000 per patient. And yearly, this ends up being over $10 billion. So the first kind of advent of negative pressure wound therapy appears to have been born out of Russia in the 1980s. There are these two individuals listed below, which I won't attempt to say their names, but they started using it in Russia for wound treatment. And they kind of started applying these to open wounds that were infected and had pus. In the United States, this was mostly introduced back in 1991 by two gentlemen, and pictured below, Louis Argenta and Michael Morikwas. And they were out of Wake Forest. And they together kind of developed what we think of as the modern day VAC machine. And then in 1995, they ultimately got FDA approval for this device. And a lot of their studies actually looked at the cell biology, and they gave kind of information as to why we use that 125 millimeters of mercury subatmospheric pressure when we use these devices. The other thing to mention too before we start, a lot of the literature out there is all over the place on what they define as surgical site infections and studies. So some, include superficial infections, some only do deep, some do both. So it's kind of all over the place. So moving further, so the application of negative pressure wound therapy at 125 millimeters of mercury, they actually found that it flattens cell morphology, which has been shown to augment fibroblast ability to release energy in the form of ATP. And in doing so, this actually promotes cellular migration towards the incision. So their research showed on that cell biology level that there was a 30% increase in levels of cytochrome C and up to 400% increases of ATP in comparison to controls with gauze under suction. They also assessed protein synthesis as an indicator of increased energy expenditure. And they discovered that platelet-derived growth factor as well as TGF-beta were significantly greater than the controls in their studies. And ultimately, these changes in cell morphology created by the negative pressure increase the cell's ability to respond to mitogenic factors and promote cellular proliferation, ultimately leading to a more mature wound. So in 2006, kind of the first studies looking at closed incision negative pressure wound therapy were published by Gomel, and he actually did an orthopedic study. So they took 35 orthopedic trauma patients with postoperative incisions considered to be at high risk of infection. They received an IVAC, and the wounds were covered basically with what we consider today as adaptic. They use kind of a standard vacuum-assisted closure sponge cut into 1-inch wide strips, and then they sealed it with conventional vac adhesive materials. They left these in place for a mean of 3 days, And the authors noted no wound infections at a minimum of 3-month follow-up in this high-risk population. So that was kind of the first studies looking at its efficacy. And then actually, I found the first studies in veterinary literature was actually in 2010. They used this on a Komodo dragon. Apparently, I guess they lay their eggs in a cave, and the dragon suffered a severe back wound while trying to lay its eggs deep in a cave. So they actually successfully treated the mother with closed wound therapy. So negative pressure wound therapy has become increasingly popular as the years go on. Originally, most of the literature used it as an adjunct for wound infection treatment, but the new age really is looking at it as infection prevention and wound complication prevention. And I think most people here, especially if you've been in the office, you start to see how annoying and difficult it is when patients follow up, at post-op week 2 or whenever, and then they have these nagging small areas of drainage or incomplete healing, and you sit there hoping that it's going to go away and it's going to heal and everything's going to be fine. So a lot of the original studies looked at risk populations, which are kind of the patients we think of normally, such as diabetics, obese patients with BMIs greater than usually 35, smokers, anytime we have posterior incisions and patients are bedbound laying on them, higher ASA grades, anytime we have implants in the body, and then further issues relating to immunocompromised states. So in 2019, there was a meta-analysis performed, and they looked at kind of the evidence in plastic surgery, cardiac surgery, general surgery, the total joint arthroplasty literature, and they compared the effectiveness and safety of negative pressure wound therapy with standard surgical dressings. They basically did a systematic review from PubMed, Embase, and the Cochrane Library. They found 45 randomized controlled trials with greater than 6,600 patients. And overall, they found that negative pressure wound therapy was associated broadly across these studies with a 40% reduced risk and development of surgical site infections compared to standard wound care. And again, in this study, there was no spine patients. So kind of getting further into the mechanism of negative pressure wound therapy. Basically, it's a closed system. It applies a negative pressure to the wound surface, whether the wound is open or closed. There's an open pore substance that fills or overlies the wound, which is generally originally what we thought of as a foam. You then place your airtight adhesive drape, and then a vacuum is created, maintaining constant negative pressure. The idea originally was that the foam would allow for improved drainage, but the secondarily found benefits were that it improved infection control. And again, the original literature published out of Wake Forest was 125 millimeters of mercury negative pressure, which was shown to promote sufficient formation of granulation tissue without compromising any sort of local soft tissue perfusion. So kind of this vacuum seal, this is going to be kind of a dense slide of information that I'm going to say, but basically on a cell biological level, once you create this vacuum seal, you have changes in the bacterial burden, which have been demonstrated with routine use of these devices. So Mouse et al. In a randomized prospective study demonstrated a significant reduction in bacterial load in the cohort of patients assigned to negative pressure wound therapy compared to the controls. And then similarly, Marikwas, again, the guy out of Wake Forest, demonstrated a decrease in bacterial burden using negative pressure therapy in experimental pigs. The mechanism originally behind these observations weren't entirely clear, although they thought it was presumed to be due to several factors, one of which was decrease in total bacterial burden of the wound by direct removal and alterations in blood flow. So it has been shown now that there is augmentation of local blood flow and promotion of granulation tissue formation, as well as reduction in bacterial contamination, edema, and exudates. So it keeps a moist environment in the wound, which is important for wound healing through this process. It removes the edema, blood, and serous fluid, all of which can contain extra inflammatory mediators, which may delay wound healing. And then it also has been shown to open capillaries that are in close proximity to the wound edge. Another factor is the mechanical portion, where the negative pressure exerts contractile forces that promote approximation of the wound edges and reduce stretch on the edges of the wound. And actually, these micro deformation forces caused by the adherence of the foam to the wound edge also promote wound healing and facilitate a favorable microenvironment to prevent development of chronic wounds. And these deformation forces actually lead to inhibition of apoptosis, changes in cell signaling and gene expression, and promotion of cellular proliferation. And on even a smaller level, its cell signaling has been shown to be changed, which includes changes in VEGF, IL-6, and IL-8. So another more recent study in 2011 actually looked at a porcine model, and they compared 5 days of either closed incision negative pressure wound therapy versus kind of our standard. At 40 days, they harvested the incisions from these animals, and then they looked at them more closely, evaluating the strain energy density, peak strain, and peak stress, which were all shown to be significantly higher in the closed incision negative wound pressure therapy groups. At a deeper level, they noticed that the width of incision in the deep dermis was decreased in these groups, as well as decreased inflammatory mediators. And overall, they felt that this could be interpreted as superior wound maturation compared to controls. Another study by that same group found that there was 63% less hematoma and seroma formation in the negative pressure wound therapy group. And they thought this was odd because there was no fluid actually in the canisters in these patients. So they were unsure kind of where this fluid was going then. So they actually did another study where they think it's actually leading to decreased dead space due to increased lymphatic drainage. They did protein tagging studies where they actually found increased protein uptake into the nearby lymph nodes in the investigative group compared to the control. So listed here are some of the currently available ones. Obviously, there's all the new different VAC types based on the modern design out of Wake Forest. And then the two that we commonly think of for closed incisions are the Pico and Pravina. So the Pravina is created by 3M. It's a closed incision negative pressure wound therapy device. The nice part is with these is they're portable, so the patients can go home, and it consists of a vacuum therapy suction unit that connects to a canister, comes with a pre-cut open cell foam that you place quickly over the incision, and then there's a non-adherent layer surrounding the foam with an adhesive drape. And the dressing in this is also impregnated with ionic silver to prevent growth of bacteria. The negative pressure in this device is 125 millimeters of mercury. Originally, when it came out, they only had it for 7 days, but they now have devices that can last up to 14 days. And again, it does have a canister to collect fluids, so you can use this, and then if it fills up, you can replace that pretty easily. So kind of going through their actual website, they list a bunch of different options that they've created. I know they've created some specifically for knees, abdominal incisions, and other parts of the body to try and better fit with these prefab constructions. And then if you go further, they actually list a lot of studies on their website. So here's a meta-analysis listed with their product information demonstrating the effectiveness in reducing SSIs and seromas versus conventional dressings. I won't go through all of that. And then another thing they talk about is the Promises trial. So it's a randomized controlled trial, multi-center study looking at 294 patients that underwent elective revision total knee, and they compare this to silver impregnated dressing groups. And they showed that this reduced 90 surgical site complications, readmissions, and decreased surgical site management costs. So overall here, demonstrating in that cohort that it seemed to be effective in preventing surgical site infections. Sorry, 90-day surgical site complications. So another study that they mentioned, and I'll touch on this one later too, was published in the Journal of Orthopaedic Trauma by Standard. I think some people probably know this study. It's a prospective randomized controlled trial, multi-center trial, where they looked at high-risk fractures, which included pilons, plateaus, and calcaneus fractures. And using Pravina, they showed that they decreased surgical site infections and wound dehiscence rates compared to the control, and those were statistically significant values. So the other thing too is to consider is, these devices do come with a cost. So they actually publish, because a lot of people ask, well, it's a more expensive device than a regular dressing. So what are the kind of implications of that? And they show that on average, using this device and decreasing surgical site infections saved over $7,000 per patient. So the other system is the Pico system, which is a Smith and Nephew system. Um, so this again is a closed incision device. It's portable. The difference here is this does not have a suction canister. So the actual bandage that goes on the wound allows kind of for evaporation of the fluid. So there is a limit to that, which they list as up to just over 1 milliliter of liquid exudate per centimeter squared in a 24-hour period. So if you have a pretty heavily draining wound, these are not good to be used. And in general, these are actually at a lower pressure rate of 80 millimeters of mercury. And again, these started at 7 days and now can be used for up to 14 days. And on average, they list these depending upon negotiations and contracts for about $300. So they also list some studies on their website. So the one they list is a study in 2016, again, coming from the joints literature. They looked at primary total hip and total knee arthroplasty in the United Kingdom. This was a single center, open label, randomized parallel group trial. And they showed also in their study that they had decreased surgical site infection rates at 6-week follow-up. And the use of Pico was shown to benefit actually more in higher risk patients. And they found that it also was associated with reduced length of hospital stays. So a lot of the original literature came out of other subspecialties. So here in 2015, there was a meta-analysis performed by Samarja, and this included cardiac surgery, orthopedic surgery, OB, and vascular surgery. They looked at 14 studies that were included. They actually removed the groin incision groups because there was such a large effect size on surgical site infection reduction. So after that, they evaluated the effect of closed incision negative pressure on surgical site infection rates, which was shown to be statistically significant. And in this analysis, it displayed nearly a 30% relative reduction in surgical site infection rates. Another meta-analysis in 2016 suggested that the use, again, of negative pressure wound therapy compared to controls reduced the likelihood of surgical site infections. The other thing that they looked at was wound dehiscence rates. So those were reported in 9 of the 14 studies. And in those 9 studies, they calculated the overall dehiscence rates were lower in the closed incision group at 5.3% compared to the control group at 10.6%. So some other high-risk patients are in the cardiothoracic literature. Obviously, patients undergoing either groin cut downs or median sternotomies. So in a prospective study of 150 consecutive obese patients who underwent cardiac surgery via median sternotomy, they used either a IVAC device or conventional dressing, and they reported a significantly lower incidence of wound infections with the IVAC device than the conventional dressings, which with the IVAC, it was 4% versus conventional was 16%. And that was within the first week of surgery. And then a study in 2018 also demonstrated similar findings where the Prevena significantly reduced incidence of surgical site infections with deep sternal wound infections that even necessitated flap coverage. There was a study that I didn't list here, but also, again, reported similar results by Maditov. They were comparing IVAC versus conventional and 115 groin incisions in 90 consecutive patients who either had a longitudinal or transverse femoral cut down for vascular procedures. And they, again, reported significantly lower rates of wound infections at 6% versus their control group at 30%. So here's some of the orthopedic evidence born out of a lot of the trauma literature. So going back to Stannard in 2009, he first reported on outcomes of 58 patients with 62 high energy open fractures. These were initially treated with IND, followed by the application of a wound vac. These were open wound vacs. These weren't closed incision versus gauze dressing. They found that 35 patients in the it was closed incision. They found that the 35 patients in the closed incision group, which were 37 fractures, were less likely than the 23 patients to have either acute or delayed infection. And then the overall incidence of this was 5.4% versus 28%. And then in the closed incision group, 20% of the patients required flap coverage compared with 13% in the control group, which was considered a confounding factor in terms of infection and healing rates that may diminish the positive effect of closed incision negative pressure wound therapy. In addition, the protocol for this study required dressing changes every 1 to 2 days in both groups, which is different than our current recommendations, which is generally we put it in and leave it on there for 7 days unless there's a reason to change it. In 2012, he again published another study, which was the one that I talked about before, which was that randomized multi-center trial in high risk lower extremity fractures, which was the Pilon Calcan plateaus. They again changed the dressings every 1 to 2 days, but overall showed a decreased incidence of wound dehiscence and total infections in these high risk fracture groups compared to the controls at 8.6% versus a 16.5%. So as a result, they pretty much concluded that they believe the use of closed incision negative pressure wound therapy should be considered instead of routine gauze dressings to manage high-risk wounds after skeletal trauma. And then another study in 2010 by Reddix. So he looked at basically acetabular fractures. He reported no wound complications in 19 consecutive patients who were morbidly obese, greater than 40 BMI. And they were managed with open reduction, internal fixation, and primary closure with closed incision, negative wound pressure. He also investigated surgical wound complications in 301 patients who underwent acetabular fraction ORIF. And this group had a lower rate of deep wound infection and wound dehiscence than the standard dressing. And the comparative rates were 1.27% compared to 6% for wound infection and 0.43% and versus 3% for wound dehiscence. So some of the arthroplasty literature, which is more, I feel like, where we use it here currently. So there's been several studies that have shown efficacy in using closed incision negative pressure wound therapy and lowering rates of PJI and surgical site infections in the setting of primary total joints. So there's 3 studies listed here. Karlaki reported that post-surgical wound exudate was substantially reduced with the use of IVACs, and there was a 4-fold reduction in postoperative wound complications after total joints in patients with negative pressure wound therapy compared with those in the control group. And their rates were 2% versus 8.4%. And then a study by Cooper in 2016 in the Journal of Arthroplasty reported on 138 consecutive patients over a 3-year period after revision total joint, and found that patients with IVAC had fewer overall wound complications than the patients with an antimicrobial dressing. And they also had fewer total surgical site infections. So again, they concluded that it seemed closed incision negative pressure wound therapy decreased the overall incidence of wound complications and surgical site infections. So moving into spine now. So surgical site infections in the spine literature occur anywhere from 0.4% all the way up to 20%, depending upon the procedure, patient comorbidities, et cetera. And this obviously contributes to substantial morbidity and revision, as well as healthcare related costs. So a lot of the interventions we currently use to prevent infection are drains, copious irrigation, prophylactic antibiotics, venc in the wound, et cetera. So in contrast, the use of closed incision negative pressure wound therapy to manage surgical incisions in patients with high risk of infection is relatively new. And I didn't realize it, but there's very minimal literature out there. So as the cost of medical care for spine surgery continues to increase, which in the last, I don't remember what time period, it's gone up over 4 times that of uncomplicated spine cases. And this generally results in large 6-figure increases in medical care costs for these patients. Another also interesting thing is if you are concerned, especially in spine patients, for surgical site infection, generally less than half those patients ever have a positive blood culture. And then the most common species typically grown from those are usually your staph species. So again, here's a list of the typical risk factors that we think about for patients that are high risk. So kind of the first studies in the spine literature, we're looking at negative pressure wound therapy for infection management. So these were your typical wound vacs. So in 2006, in the European Spine Journal, 15 patients with deep subfascial infections after spine surgery were treated with a wound vac. And this was a retrospective study. In 7 of the cases, they exchanged the implants. 5, they removed them completely. And then in 2, they had laminectomy without instrumentation. So overall, they noticed basically kind of as a preliminary trial, this seemed to be a safe, effective method, and it was useful as an alternative for wound conditioning in these patients. And then over time, multiple studies have shown that implant removal, obviously with extensive wound debridement in these patients, has satisfactory results, but the inevitable risk is that you then have collapse of your disc space, pseudoarthrosis, loss of normal sagittal balance. The last thing you want to do is end up having to take hardware out of a spine that you just put in. So 2022, there was a systematic review by Kahn that showed the application of wound vac therapy amongst 106 patients in a pooled cohort was successful in eradication of surgical site infections in 80 of these patients. 26 patients did go on to require implant removal despite undergoing vac therapy, but ultimately the absolute risk reduction in implant removal after vac therapy was 16.6%, and the relative risk reduction was noted at 40%, which led to a number needed to treat of 6. So another study, this was in 2005, again, looking at deep wound infections in adults after spinal fusion. So they looked at 20 patients with deep spine infections, median age 55. 8 patients had a combined anterior posterior surgery, 9 posterior, and then 3 also had T-lifts. 16 of the 20 patients in the study had draining wounds less than 6 weeks post-op. The other 4 were greater than 1 year out. So they performed on average 1.8 INDs prior to wound vac placement. And then after wound vac placement, they subsequently had 2.2 procedures, which included the wound closure procedure. The wounds were closed on average 7 days after vac initiation. They were placed onto an antibiotic course, typically IV for 6 weeks, and then orals. And they reported no adverse events with all patients. All had good wound healing, as well as were able to maintain instrumentation greater than 6 months out. And then lastly, as far as infection management, there's a pediatric study in the Bone and Joint Journal in 2008. They evaluated 14 pediatric patients with early deep surgical site infections, 12 of which were high-risk kids with neuromuscular syndromic conditions. This was a predominantly female cohort. And then infections in this group presented at a mean 16 days post-op. And then the wound vac application was on average placed for 21 days. And again, they were transitioned from an IV to oral regimen. These were changed twice weekly, and 12 of the 14 were allowed to heal by secondary intention. No patient in the study, again, had hardware removal or further surgery at a mean follow-up of 44 months. And then also they reported later from this study that there was no contraindication to wound vac therapy in hybrid posterior constructs using implants such as sublaminar bands. So this is kind of the end of the talk where I move more towards what my original goal was to evaluate the literature for closed incision infection prophylaxis in spine surgery. So overall, there's only like 4 to 5 studies on this in the literature. One of the first ones was in 2014 in Spine Journal, looking at long segment thoracolumbar fusions. So in 2012, the author of this study made a categorical change that included postoperative routine use of IVAC therapy after primary wound closure in all of his long segmented spine fusions. Before 2012, he did not use this. So they did a retrospective review of the first 46 cases in which he used the IVAC and compared them with the immediate preceding 114 cases to assess the incidence of wound infection and dehiscence. They followed these patients for 90 days post-op and found reduced incidence of wound infections at 10.63% versus almost 15%. They decreased wound dehiscence rates by 50% from 12 to 6%. All patients notably had subfascial drains that were removed at 48 hours post-op, and intraoperatively, their protocol was that the incision was cleaned with chlorhexidine after wound closure prior to placement of the PICO system. And then another interesting kind of thing they found was that in their negative pressure wound therapy group, they had a higher rate of gram-negative bacteria in their surgical site infections than the control group. Another study more recently by Octor at Ohio State, they published a retrospective review comparing IVAC cohorts to traditional dressings. Each group was comprised of 42 patients. And again, similar to prior, there was a shift in surgeon preference for wound closure on all of his posterior fusion procedures. This was a single surgeon study. And then the same use of implants as well as graft materials was noted in this study. There was no difference in rate of readmission between the two cohorts. There was a higher number of surgical site infections in the control group at 7.1% compared to 0. The superficial dehiscence rates were 7.1% in the control group versus 2.4% in the investigative group. They noticed a decrease in seroma rates by 50%, and then decreased need for additional outpatient care and operative revision. Similarly, wound complications were higher in the traditional group compared to the IVAC group by 50%, although this did not reach statistical significance with their numbers. And then overall, surgical site infection was the only factor to reach statistical significance. They did note that tobacco use in their study was actually higher in the IVAC group, which would portend they are a higher risk group to begin with for development of wound complications, even though they had lower rates compared to the control. And although 7.1% rate of surgical site infections in the control group appeared abnormally high, 3 of the 42 patients who made up this percentage, only 1 required revision surgery, while the other 2 were treated for superficial infections with antibiotics alone. 2019, another study that looked at 64 patients, 21 with IVAC versus 43 matched patients with traditional dressing, single center study with 1-year follow-up. They were looking at a consecutive series of high-risk patients. And in their study, what they considered high risk were posterior open surgery across the cervicothoracic junction, thoracic kyphosis due to metastatic disease, high-energy trauma, multi-level revision, reconstructive surgery. So patients in the VAC group also met 1 or more comorbidity criteria, which also included BMIs greater than 35, diabetes, previous radiation, surgical site, chemo, steroid, bedridden, or large traumatic soft tissue disruption. So what they found was that VAC patients overall did have longer surgical times and were prospectively selected as patients with a higher probability of wound complications. Although this study had a trend supporting decreased surgical site infections in this group with the IVAC, even though they were at higher risk, strengthening the conclusion towards the efficacy of prophylactic negative pressure wound therapy in these groups. Study by Mueller in 2021 in neurosurgery, also a prospective observational study in 274 patients, so a little bit bigger. They had 118 in their IVAC group. They found no statistical difference in non-instrumented cases, although they still noted a decreasing surgical site infection reduction trend. They did find a difference in the instrumented cases in their IVAC group, and they also noted in subgroup analysis that it was more effective in higher risk patients. They reported their 60-day outcomes. The Prevena was left in place for 7 days. Again, all had subfascial drains. The higher risk patients in this study were obese patients, smokers, as well as had increased multi-level surgeries. And again, this study also reported that the predominant bacteria was staph species. So those were kind of the 4 main articles that are out there today. In 2022, out of China, they actually did a meta-analysis of this because this is really mostly only the literature that's out there as far as closed incision negative pressure wound therapy in spine. So this meta-analysis of the 4 prior studies was published in the European Spine Journal, and they found when you put all these together, there was significantly lower incidences of surgical site infection as well as overall wound complications, which did approach significance. There was no difference in wound dehiscence, readmission, reoperation rates when looking at all the studies together. And I think this kind of really highlights the lack of research and limitations in this area. The current limitations are that most of these studies are small sample size, retrospective reviews. There was some variation in retention time of the IVAC therapy across these studies, as well as follow-up varied from anywhere from 60 days to 1 year. So some of the FDA reported contraindications for IVAC therapy are necrotic tissue with eschar present, untreated osteo, non-enteric and unexplored fistulas, malignancy in the wound, and exposed vasculature, nerves, organs, and anastomotic sites. Additional risk factors to consider are patients that are at high risk for bleeding or hemorrhage. You obviously don't want to keep sucking out their blood if they're just going to keep bleeding. And then patients that are on anticoagulants or platelet aggregation inhibitors. So There's also, I believe, one study that showed it is safe to use even if you have exposed dura. The recommendation is that obviously if you don't have a watertight closure, if there is a durotomy intraop, then you should probably not use it. But there is a case report published that they did have an intraop durotomy, successful dural closure, and they did use an IVAC in the patient without subsequent problems. So kind of the future of this, obviously there's not a single published randomized controlled trial looking at IVAC and prevention of surgical site infection and spine surgery. There is reportedly online a clinical trial, I think it's out of Michigan, that's listed, and they were looking at strictly BMIs greater than 35 and the prophylactic use of IVACs. But honestly, I think this is a pretty much unexplored area and would be something good to look into further as to how this kind of plays out. So another thing to consider, like I talked about before, is cost of these devices. The average cost is anywhere from $500 to $600, depending upon your contract. We obviously don't have the literature in spine, but previous studies show that with an IVAC, you can decrease surgical site infections. This could drastically cut healthcare costs over time, decreasing need for postoperative revisions and further medical care. Here is a table listed, I believe it's from the prior meta-analysis, kind of what the current summary recommendations are for negative pressure wound therapy and spinal surgery. At this time, it does appear that deep wound vacs can be effective in managing spinal surgical site infections. Closed incision techniques appear to be effective at preventing surgical site infections. And there isn't literature to determine whether or not routine use is beneficial broadly, but it does appear in a lot of these studies published that higher risk patients throughout their subgroup analysis benefit more strongly. So that's the end. If anyone has any questions.
I have a question.
Yes.
Great review. I think the literature is clear on open wounds, but I have a couple of questions on closed wound management. You mentioned that the bacterial counts are lower when you use the VAC. My question is, if the wound is closed, how do you get a bacterial count? What do you open the wound up after it's healed or while it's healing to check what the count is?
I don't remember. Those were the studies out of Wake Forest early on. I don't remember exactly how they analyzed that.
I think, I believe those, what they're talking about is bacterial count on the skin surface adjacent to the incision. They didn't reopen.
I don't know if skin flora, if that bacterial count on the skin flora is, is the main issue here. The second question is, most of the studies, if not all the ones you presented, compared closed management with the VAC to a standard bandage of gauze.
Mm-hmm.
Why is no one doing closed management with the VAC and closed management without a VAC? In other words, using the exact same bandage and to one adding the VAC for 7 to 14 days versus just leaving a closed bandage on for the same amount of time, because you're now comparing apples to oranges. You don't know what part, if both are necessary or only one is necessary.
You're saying leaving a kind of well-adhered vacuum sealed dressing in place for 7 days versus negative pressure therapy for 7 days?
Well, the only two changes you're making is, one, you're closing the wound and making it a closed unit. And the second part of what you're doing is adding the vacuum assist. So you're adding two things that you aren't using with just the regular bandage, which is open. Like in 24 hours, it's not even, the tape falls off. But wouldn't that make more sense to do a study that compares with and without the vacuum to see whether it's the fact that it's open bandage?
No, the regular bandages in those studies are occlusive dressings that stay on for a week and are not touched.
Well, the way it was presented was they were using standard gauze bandages.
Well, it's the literature in the total joint literature comparing closed incision negative pressure wound management is compared to occlusive dressings.
Right. So again, the point is, there's no reason you can't just put the same exact dressing on. I think it would make your case stronger rather than using two different types of bandages.
Yeah, so the spine literature varied as far as most of them used Tegaderm and gauze. The joints literature, it looked like it was more kind of the like Mepilex or Aquacell bandages versus we don't really use that in spine. And most the limited studies that were there mostly used Tegaderm and gauze.
I think also in spine literature, it's minimal at this point. They some of the studies, half of the studies actually were compared to a retrospective cohort.
Yeah.
So it's meaningless, essentially.
Yeah. I mean, and for me, it further highlights the need that this is a very unexplored area, especially in spine surgery, that while there is some evidence out there, we really don't know.
That's a really good look at that and well explained. You did a good job of also explaining the contraindications. Did anybody have a consensus on indications? Like, is there a recommendation to try and do this with all the patients in future studies, or
So
was there anybody that was pushing for that?
I mean, it seems like from the limited literature out there, they say, especially when you look at the subgroup analyses, that the higher risk patients, higher risk incisions, higher comorbidities, et cetera, seem to have better results than kind of your standard uninstrumented, small incision, healthy patients. So I think as a starting point, probably using them in the higher risk patients seems to be a little more efficacious at this point, based on the limited literature that's out there.
Was there any look at other adjuvant treatments, like somebody that's high risk, drop a gram of, vancomycin in the wound, or they were excluded or not included or included?
I believe the studies that had instrumented, it's become somewhat standard of care in spine surgery now to use vanc powder, especially in instrumented fusions. I believe the studies that I have here, I think all of them did have vanc powder included. And then they also noted that those retrospective reviews, there was no difference as far as surgically what implants, graft materials, vanc powder, et cetera. There's no difference between those cohorts. The only difference was the actual bandage.
Matt, thanks for a good overview. I have, I guess, what's more of a practical question. So let's say we put this on a patient, they go home, it's day 3, it's day 4, the canister fills up.
Mm-hmm.
Okay. What happens at that point? Does the patient know the canister is full, or does the dressing just get saturated to the point that it eventually starts to ooze through the occlusive dressing? Does the patient have the option of exchanging the canister? If exchanging the canister is not, if exchanging the canister is an option, how the heck do you get that canister to the patient when they're home, or do you just abandon the dressing and go to the standard Tegaderm and gauze at that point?
So it depends.
And that's a great question, because they're going to call when I'm on call at 2 a.m. Thank you.
So the Pravina is the one that has a canister. The Pico does not. And so if you think it's an oozy incision or something like that, and you're concerned it's going to be a little more substantial, you would not use the Pico dressing, because that, again, is that kind of 1 milliliter per centimeter squared area in a 24-hour period. So it's meant for pretty much minimal exudate.
Yeah, prevent Pico. I mean, forget Pico. I'm talking Pravina.
Yeah, so Pravina, and we do that all the time on the floor. So if it fills up or they have increased drainage, you can actually hook those to a regular wound vac machine or wall suction. They basically I guess play together or whatever. So you can hook those directly to wall suction too. So, but yeah, there's just replaceable canisters. So they can even go home with one, and you can give them that, or even in the office, and they could stop by, and all you do is just unplug it, put in your new canister, and you're done.
So do any of the joints guys on the call have any experience with that? Do you have canisters in the office that you could give to patients once they're home and their canister fills up? I mean, I would imagine that the only way to get this is through the hospital.
That's correct. Yeah. So if it's a patient who's got a very large wound, or if it's a revision, or if it's a wound where I'm anticipating drainage, then we will try to, before they leave the hospital, have them take home extra canisters so that that can be switched out. The larger dressings have larger reservoir canisters, and so those larger units usually do not need to be exchanged. There are times where patients have gone home, it fills up unexpectedly, and then the options are, the machine basically stops working. You leave the dressing on because it's occlusive, and so it doesn't expose the wound to air. Or you can send the patient back to the ER, which is suboptimal, but we've done that, to be evaluated by the PA, and then we can get, or the resident, excuse me, and then we can get them to swap out the canister or sometimes the dressing. The reality is that if you have a wound that is overwhelming the capability of the machine, then that's usually a surgical problem. So there is, while these dressings have been a game changer in managing high risk primary wounds, revision wounds, the reality is that there's a limit to what they can do. And so if there's, excessive drainage, past the 2-week mark, or even within that 2-week mark where, the dressing is really not cutting it, then that's usually a surgical problem.
I think another issue with spine is if you're using any kind of negative pressure device, but you're also putting in a drain, you really don't have negative pressure.
Yeah, I mean, in most of these studies, it was subfascial, and I guess, I mean, as long as you have a good fascial closure, then
you still have an exit, you still have another canister to deal with.
Yeah.
You have junction, so it kind of defeats the purpose. Because what you're doing with the subfascial, even with a subfascial drain, you're creating negative pressure and essentially pulling from your hematopath.
Yeah.
As in addition to the wound, and that really doesn't make any sense. So if you want to do a trial of negative pressure prophylactically on the spine, that would either one or the other. Compare it with just subfascial drains. You can't use both and say it's superior because you defeated the purpose.
Matt, that was a great review. Just from a historical perspective, which I hate to say, but that means I've been doing this for a while. I was an intern when these in 2000, when these started taking off. I was on the plastics service, and it seemed like a crazy idea. It seemed like voodoo that the plastics guys were starting to use, and they were putting it on everything. And it was hard to believe at the time that this was something that could work. But it goes to show you that, an idea with some science behind it can really change medicine. And so for the young investigators in the room, speak up about your ideas, because they may have potential. You mentioned contraindications. I've seen one of these go awry when it was placed over an amputation, an AK amputation, and the femoral artery cut loose. So you do have to be careful where you use these, because they can be fatal. That one wasn't, but it was close. A question I have about your literature review. We've come to use these on fasciotomy sites, particularly in the leg. And then when you do that, it seems like it granulates well. They start to heal. They start to even epithelialize. But then you mandate a skin graft. Would you say that's true? And is it counterproductive in that stance, and that we've come to using them too much, and when we could potentially close those wounds primarily in a delayed fashion?
Yeah, I don't know if I got too much into. So, I mean, a lot of them discuss the use, and that was some of the hand literature is used for skin grafting and stuff like that. But I don't know if I necessarily got into the fasciotomy realm about whether that's helping us or hurting us. I
Yeah, that
mean,
wasn't the gist of your talk. I was just curious. I've
Yeah.
been curious about that.
Yeah,
Okay.
I didn't. I mean, there was I think there was a study comparing before wet to dry dressings versus IVACs, but that was just in open incisions, which I think the IVAC showed better results than the wet to dries. But as far as outcomes of fasciotomies, I'm unsure.
I've done it both ways. I don't think you're doomed to doing a skin graft, but it is wound dependent. And if you've had the vac on long enough to create that beefy red granulation tissue, in many cases it's just too difficult to mobilize the skin. You can elevate it, but then you're kind of reopening that wound. So it can be done. It just has to be done on the right wound. And you can always go back at a later date and size the skin graft and for cosmetic purposes. But I think you're right. To a very real extent, you are committed if you've used the back for an extended period of time to have to.
If Tim Letty says I'm right, then we can end this conference.
It's over.
All right, thank you guys.